So welcome to NUR203 Pediatric Nursing. My name is Professor Bogart. I've been with Fortis now for over 9 years. I came in on campus, I taught pediatrics on campus, and I taught pharmacology on campus. So I am your go-to person for dosage calculations. If you don't know it, I can show you a method that's going to help no matter which formulas you use. I don't do ratio proportion. I've got my own type of formulas. See right there, 201, one more person came in. I told you, it always happens. So I am a big wealth of knowledge. You only have to reach out and ask, and I will work within your schedules. The only thing I request is I don't like early mornings, so late mornings is better for me. Um, I have rheumatoid arthritis and I don't function well in the mornings. I'm stiff mentally, I'm a little bit slow, so you want me at my best. So late mornings are better for me. So I lecture in pediatrics, and how I do my classes are I'll come in, I'll give you the announcements. I'll tell you what is due for this week. This week you have a discussion question. The first one was due last night, the initial post by midnight. Be careful with that initial discussion question. It's not just talking about who you are, there's also a question about nutrition. And nutrition is the basis of growth and pediatrics. So it's a very important concept. Now, if I go through and I see that you've done the wrong discussion question, I will give you a 0. I'll send you a message. You still can make it up and you'll get your full points that you're supposed to get. I will not hold you accountable for that. It's the first week. You've got 3 classes. You're just trying to make sure you get to class on time. So that's one thing I do that first week. So I will be doing a lecture, and I'll do that by a PowerPoint. Now, I don't read PowerPoints. I just tell you the concept that's there and explain it in a manner that hopefully that you'll understand. I do post all my lectures on a YouTube channel. You can look at a lecture before you come to class. I've been doing this now for, I think it's 6 years. So you've got YouTube posts from wherever. You've got dosage calc. You've got all of the classes, HESI reviews, et cetera, if you want to go and you look at them. They're a wealth of knowledge. And that's Professor Bogart, Pediatric Nursing, in a YouTube channel. So that's also where your class will be posted. You will be getting your class postings usually within 1 hour after class. I think that some students all of a sudden have this concept you just got. Some, not many, but some will say, gee, I would like to hear that again. I'm confused. And immediately then you'll have that recording to go back and look to. So that's one thing I do. Some professors do it the next day or later that night. I'm trying to get it to you as quick as I can. So today, what are we going to do? We have 2 PowerPoints. One is about all of the rules and regulations on online nursing and what my expectations are for you. If you don't know what I want from you, how can you give it to me? So I'll tell you what I need. And I think the number 1 word will be communication. Talk to me, I can help you. You don't talk to me, I can't help you, and that will break my heart. So please talk to me so I can help you through this whole thing. So we'll be doing that review, and then we're going to do our week 1 PowerPoint. There's a lot of chapters. And you're like, how are you going to do a quiz next week on all those chapters? Well, I gave you the PowerPoint and I give you a Kahoots that hits all the concepts. You'll be just fine. As long as you go back and you review. The one thing that I do ask all of you, and I find that this is the thing that helps students be extremely successful in pediatrics, is look at the information before you come to class. You know, you don't have to understand it completely, but know these little things that are going to be coming up. That's your first time that you've looked at it. You come to class and I give you a lecture and I talk about children, my past experiences. I try to make things understandable that you get what I'm trying to teach you and you can apply it to practice. All right. Then I give you a Kahoots and I tested you. Now that's 3 times that you've seen the information. We have seen, and the research has proven, that the more times that repetition, it helps students understand it better. So if you can do it, come to class prepared, listen to me, take the Kahoots, and then look at the Kahoots. What concepts don't I know? And then study them. You're going to do extremely well in this course. I do give exam reviews. We do give study guides for the exams, not for quizzes, okay? And then the last thing we're going to do, of course, is my Kahoots, and we're going to introduce you to them. Now, Kahoots, I just don't do questions. Again, I am repeating the information you need to know about the answer that's given on that Kahoots. So if you don't get it, understand by then, write down that concept. I'm still, got the fog here. I've got a blank. I've got a wall up. I don't get it. Write the concept down. Do your research on it. If you can't figure it out, please contact me and I can walk you through it. I can make things sound so simple. All right. I don't think big words and big technological words do you any good. You want to know how things work as simplistically as possible so that you can understand it the best. All right. Let's start with our first, the rules and regulations of online. Anybody with any questions so far? Okay. Now, do not be afraid at any time to stop me. I don't get upset. It doesn't bother me. All right. If you don't know something, please. I'm sure somebody else doesn't know it also. Sorry. Okay. Online nursing. Now, there are similar PowerPoints in every single class. So I'm going to go over the key concepts within this class and all of these things that you need to know. And again, this is your reference. And of course, your student handbook is your guide and your Bible of what is you need to do and what's right and what's wrong. Okay. So we know that if you have any problems in Canvas Shell, some of you have reached out already. I had one student even from another class saying I couldn't find a Zoom link, or I couldn't find this, or could you resend me the handouts? The reason why the handouts were sent in a different way, and two ways, announcement and through Canvas, a student reached out to me. So again, you reach out to me, you're helping yourself and probably some other students who are in the same boat but didn't ask, okay? So again, please contact me first. That's what you want. Now, here is my phone number and here is my email. Now, this is my personal phone number. You can text me if you need something that's emergent. I know that, I've just got done finishing a PhD program. I went back at age 53 and did BSN, MSN, PhD. I know what it's like that if you've got 2 hours to sit down to do something, and if you don't know how to do it, that's 2 hours that you really need to put something in there because you have no time. So that's what I call an emergency. Text me, don't call. Text me. Let me know what's going on. If I need to call you, I will call you right back. And that number is 305 951 8055. You will see that in my announcements. You'll see that on my About the Professor, Professor Bogart. You have the number all over on the Canvas shelf. You need it. But please just be respectful of it. I don't like early mornings, but if you're in that big, I can't do it. Yes, that's the only time I'd say fine. And I'm usually awake till, evenings, later evenings. So again, I'm pretty good at answering pretty quick. Now, I'm not answering you. Something's going on, and you need to speak to someone right away. I do not mind if you get a hold of Dr. Brown. I will not get upset. I will not get in trouble. In fact, we work as a team, okay? And we talk to each other all the time. It's not a problem. Her email is not D Brown, it's Darlene.Brown. Believe it or not, there is another D Brown in Fortis somewhere. Okay. And that is her work phone, 720-665-6101. If she doesn't pick up, leave a message. This woman, I don't think she sleeps. She will answer you pretty quickly. And she does have these open windows where you can go and talk to her about any problems you see, anything that you think that we can help correct the program, make it better, or things that are frustrating to you that you don't understand. You want that final, this is the big boss. I need your okay, Dr. Brown. And she doesn't mind. The only thing when you're communicating with us is just to be respectful. That's all we ask. Be professional in the way that you talk with us. And of course, and I never knew this about putting caps on a text message that it seems like you're yelling. I didn't know that, but just don't do it. So, online courses with the schedule and attendance. We know that every week, Thursday, 2 p.m. Eastern Time till 4:41 Eastern Time is class. We know every day that there is a quiz, like next week, it is at the beginning of class. So you need to get to class on time. All right, be sure that you do that. Know that all the activities, discussion boards. Now, by Friday, I'm going to pick 4 or 5 students out, and I'm going to, according to what they've written to me, I'm going to write something that elicits more of let me think about that and let me respond. It's more of a back and forth, even with me there, not just with other students. And then, of course, you've got to do your 2 peer reviews with it. This is something that the accrediting agencies came through and said that we needed to improve on. So it's something that we're doing. And it also, I've always given you vast information on these discussion posts, but they want it more interactive. So that's what we're going to do because it gives you more information from, quote, the expert, me, which knows more about pediatrics, right? Remember academic integrity, and I know this is something that's been, very highlighted recently and lately and will always be. Do your own work. Okay, I was not an A student when I was in nursing school. In fact, if I told you what my GPA was graduating nursing school, you'd go, huh? It doesn't match. I don't test well. I don't, testing just drives me crazy. I don't know why, but I did with my own work. I never cheated. I did pass nursing school. And of course, my BSN, MSN, even my PhD are 4.0s. But up to that point, no, it wasn't. But I took what I knew, and then I know where my basis is, and then I grew from them. So please try to do your best job and your only work, all right? They are looking at this very, very, very carefully. Um, the AI that's up there right now, discussion posts, I know you like to use them. Do me a favor. Change a couple words in the discussion post from AI and make it more your own. That's all I'm asking. I don't want to cut and paste. You don't learn from that. Change a couple words. Now you have to think about what it's telling you, okay? The American Nurses Association is what we live up to. It's the Hippocratic Oath for physicians, right? This is what we call our code of ethics. Again, being professional at all times. It's not negotiable. It's not at all. Nursing is a precious, precious profession. You know how long I've been a nurse now? 50 years in June. 50 years as a registered nurse. I've done everything but delivery and an operating room nurse. I've been everywhere and seen everything, and I've enjoyed every moment of it. And when I get bored, I move to something else. And that's what you have in your future. But to do that, you've got to understand it and know it. So do not use resources that aren't your own. Do your own work. They know all of these cheating sites. I mean, some of them are Sudoku, Coursera, Stuvia. I mean, there's many. They know what they are and they're looking for them. All of your papers go through plagiar checkers. ExamSoft is now doing multiple exam, site checks. Again, just work. I give you everything you need. Use it, okay? If you cannot get your work in on time because you got sick, your kid got sick, your computer broke, whatever the question is, let me know before the assignment is due. Okay. If you tell me before the assignment's due, you will have, another week in order to get it done. All right. After 1 week after that, it is a zero. Now, if you don't tell me what's going on, you will get a minus 10% deduction if you get it in. And I will be sending reminders to you. Again, communicate to me before you miss class, before you miss a quiz, before you miss an exam, before an assignment is due, before. Communicate. Attendance in online classes is actually done in two different ways. It's done by me and you, Zoom attendance, and I submit that immediately after class every day with a Zoom log, okay? The other way they look at attendance is going into your Canvas shells. Make sure you go into those Canvas shells every week. I mean, if you're doing your work, you are. I'm just warning you. You get out, you get sick, something happens, go into the Canvas shells. And again, communicate, let them know what's going on. On Zoom, you don't have to be in a uniform for me. I mean, some professors like that. I want you comfortable, but don't be revealing, exposing, be professional. All right. That's all I ask for you. No pajamas, etc. Be professional. Attendance. You know that they look at attendance very carefully. When you miss 5% of your attendance, they will send you a message. 10%, a message. 15%, a message. If you reach 20% of attendance and do not have any documentation to show why you missed that class, you will get a full letter grade decrease in your grade. So, what I tell you, if you miss a quiz, yeah, you cannot make it up, but if that quiz will pass you at the end of the term, that's all you need to pass, you can appeal it as long as you've already submitted me the documentation when it happens. Okay? So give me everything. It could be a speeding ticket. It could be a doctor's visit. It could be a court thing. It could be an eviction notice. It could be anything. I've seen everything. All right? Documentation can save you. Last term, I got somebody saved with because the documentation. She needed 0.1. She did the quiz and she passed. So again, I see it all the time. I'm trying to help you. We know all about attendance, and I've talked to more. Now, they are now telling you all about alcohol, tobacco, drug use, and all these testing policies. We know we're all tested for, alcohol and drugs, et cetera, et cetera. And that's just part of nursing because we want your minds to be free and clear to be able to be a nurse. Now, they say students are forbidden from vaping, smoking, or using tobacco products, oral tobacco, marijuana, or anything in uniform, in public. I mean, I've seen students to try to use their vapes on camera. No, please. That is very unprofessional. Don't do these things. When we as nurses go out there and don't act professional, we are making our profession less than what it is. We work hard to be nurses, and we work hard every day practicing as nurses. So just be respectful of it. 7 keys to success basically is know what you need done. I send it in a announcement every week. Now, you have some professors who love announcements, and you might get 3 every day. I do not do that. You'll see usually 2 announcements every week. One on Sunday, that will be week 2 information. That's the information week. That will show you the chapters, which will show you any handouts and the assignments that are due. That can be check when you do them. That could be part of making you organized, okay? The second announcement I sent you is week 2 recordings. I will send you the recording for that lecture, and I'll send you the handouts again. And maybe I had an answer sheet for a handout. I will send it then also. That's the only 2 you should see from me. If you get another announcement from me, please read it. It's important. It's to help you. All right. I don't go blah, 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 blah. I give you only what you need. Okay. And if it can wait till class, I will tell you in class. All right. So always know going back in your Canvas, make sure that you keep checking it. I mean, everybody has it connected to phones today. It's just so easy. We check it so much. But again, that's again keeping your attendance. To be successful, I think the big number one is just please contact me, be in contact with me, let me know what's going on. You're not bothering me, tell me what's happening and I can help you. If you don't let me know why things are going on, why you're late in assignments, why you missed an assignment, why, I can't help you. But if you explain it to me, then I can work. I will work with you because that's who and what I am, all right? So we know getting into Canvas, you got to go through all those things and tests that you got to do in order to be able to get it done. Now, I will say after class, if anybody has any questions, I do have a class that starts about 5:30. So but I am here for you for any questions, etc. And I can come before class. Anybody who needs any questions, any concepts they're not understanding, please just let me know, okay? We will be doing exam reviews. And I believe I've already set them up. The only day of the week they don't have any is on Thursday and Sundays. So Monday, Tuesday, Wednesday, Friday, Saturday reviews, all different professors that you can get to. And again, they're recorded and I put them in one announcement. I keep editing it, but one announcement that are just the reviews. Anybody who has accommodations that needs help, or you're in a reentry or a repeat, please meet with me. Okay, let's make up some routine. I don't want to see you again. I want you through and you deserve to get through. You get to pediatrics, you've got one more term. You got to get it done. So please come to me. I will help you. We have all the tools. I'm going to show you how to use them. If I have to, we'll do it together. So have you passed the course? You needed 78 on your KGA, which is 80% of your whole grade in total, and that is your exams, quizzes, and your HESI. I have all sorts of HESI review materials, and we usually do pretty good on the HESI. Just to let you know, because it's usually everybody, oh, I don't do good on the HESI. No, we actually do pretty decent on the HESI if you do what I tell you to do. The other 20% is homework. And again, the one thing I'll tell you, do not hand in anything less than a 78. Why do I say that? I've seen students have a 78.0 on the KGA. You add in the homework and they fail the course. That just hurts. And that's homework. So again, I know you don't get hundreds on every single assignment and you'd love to do that, but if you're in that week of a rush, don't hand in anything that's less than a 78. Then when we add in homework assignments, you're not going to fail because of homeworks, okay? That is just some advice I'm giving to you. Homework grades are turned off for the first 5 weeks just to show you what your KGA is, and then we add in the homework grades. It shows you how those numbers affects up or down. What does your grade look like? I do turn them off on week 8, so only KGA will show, and it will not be turned on again until final grades. Already told you all these things. Exams, not quizzes. I don't bring you in on quizzes on 2 devices. I keep you on 1 device. We do our own review. I do my own check that I do. And I'll tell you every time, do your own work. I know when you go off your, when you're on Canvas and you try to go to another URL and look stuff up, I know when you go off Canvas shell. So don't cheat, do your best work. And quizzes are not on 2 devices. Exams, yes, absolutely will be. We'll do the single review, et cetera, et cetera, et cetera. Quizzes, brand new this term. I'm crazy, but I've made up all new sets of exam quizzes. Only 1 attempt on a quiz, all right? And if you miss it, you missed it. You cannot make up a quiz. The only time is, it's like that student had only needed one quiz. She was late to class for work or whatever reason, and she missed the quiz. That quiz, when she did it, passed her because she had the documentation. She had the boss write her a letter. She had it in the beginning because that was quiz one. Okay. She went back and did it and she did pass. That's the only time. Besides that, no. Even sick, hospital, no. You cannot unless that quiz will pass you. Make sure quizzes again. The big thing is keeping on camera. Students tend to like go like this and go off camera, because you lean, you're tired, or this way on the camera. Make sure whole faces are on for quizzes, exams. They are really getting picky on it. Exams are through ExamSoft. Make sure you do the practice exam. And the reason, if something happens during that first exam and it's glitches and you did not do that practice, they're going to say it's your fault because you didn't come to practice with all of your equipment ready and available. So make sure, do it in every class. Okay, yes, every class. It shows that you have made your equipment, that you are prepared, and then they'll do everything they can to get you the exam done. Okay, that's the big thing about ExamSoft. And remember, they're looking for glitches, they're looking for cheating, they're looking for remote devices, they're looking for everything. So be careful. Do not do it. Do your own work. I give you the best study reviews. I give you the best Kahoots and PowerPoints. You've got everything you need. You just gotta study. All right. If during the exam, all of a sudden your computer turns black and oh my goodness, you can't get it back on, what do? Call me, text me, email me, whatever me. Stop. It's okay. Your test is not lost, no matter what. I can get that exam started at the same place that the glitch happened. And we will do the rest of the exam whenever you can. All right. But before the next class. So, again, what do you do if something happens, a quiz, exam? Computer turns black. Let's call Professor Bogart. Let's text Professor Bogart. Okay. That's all you have to do. You're safe. Don't get a panic attack. You're all right. I'll take care of you. Anybody who has accommodations, I need your letter from Dr. Foster as soon as you can. I have to make sure Dr. Brown has it for your first exam and all your exams. I also have to make sure that I give you extra time on quizzes if you need it. All right. I also want to know how you want to take your exam. Some students just come into regular class and do it. Some students want to be in a breakout room alone. Some students do it on campus. Whatever. I don't care. I will work with you. I have to know at least 3 days before because I have to make different exams for everywhere it goes. It's the same concepts, different questions, okay? But it's the same exam. Now, if you want to take your exam on campus, you need to tell me who is going to do it. Then the who that's going to do it must email me. I need to validate who they are. I need to say, okay, they're good, they can do it, because I have to send them an access code. This has to be done 3 days before. That means by Friday. Okay, the Friday before the exam, I need all of this information. Okay, I will work with you. Not a problem. After the exams, there's always a class. I will tell that proctor when the class will start. So you'll all be organized and taken care of. You do what I need, I'll take care of you. Again, exams are on Zoom. You do IDs, we do all of the reviews and all that sort of stuff. Again, anything that you need for exams that's not the normal, I need to know about it. Let me see what documentation and how you're going to deal with it. All right. Exams that you miss and you don't tell me you're going to miss, and there's no really valid excuse, like you were in a car accident in a hospital and you couldn't talk. Well, that is a valid reason, but just you didn't call. There was nothing. You can take that exam when you contact me, but it will be a minus 10% deduction because you didn't talk to me for no reason. You didn't call me. If you were in that car accident, I'm going to work with you, no deduction, and I will get your exam done. The other thing about exams missed, they must be done, unless some really crazy stuff, before the next class. So if you miss a class on a Tuesday, it must be done before the following Tuesday, okay? If you don't talk to me, if you don't reschedule, you get a 0. Exams, many times in appeals, and I'm a part of that appeal committee, students want to repeat an exam due to they were sick, they were this, they were that, and they didn't tell their professor before. You can't take an exam to improve a grade, okay? Because of whatever. You needed to tell that whatever to the professor, and they can work with you, okay? Another thing, at the end of the term, and you need to appeal an exam, a HESI, a quiz, homework, whatever, it has to be filed no more than 72 hours, 3 days after the grade's been posted. You've got to get that appeal form in. I will give you that appeal form. You will have that in plenty of time. I always give that on week 11 so that you have it here in your hand, okay? Any appeal, you must put on that form. And if you don't have documentation, it's not going to work. Again, I have the documentation, you have the documentation. Please just attach it. Don't assume I'm attaching it. You need to make a pretty picture. This is the car accident. This is the hospitalization. This is the this. This is the that. And we look at dates and times and exams, dates and time. We look at it very carefully. So send it all in. We want to approve you. Give us the information. So again, tell me before you want to test that you don't feel good if you're ill. I've had students come to class for an exam and I'm doing their check through and they're squinting and they're holding their head. And I'm like, what's going on? They go, I have a massive migraine. I'm like, you can't take the test like that. Let's reschedule. And they're like, oh, thank you. I didn't know I could do that. Oh, yes, you can. Tell me. I can help you. Don't tell me after that you got a 46 because you didn't feel well. Don't do that. I can help. And there's all different sorts of, things that we do see. Again, documentation will prevent that 10% point deduction. And it must be done before next class. Again, tell me before, not after. So quizzes are in the modules. And next week, again, you'll be doing exam quiz 1 through the modules. And again, just come in on your computers. I'll do my little security check and know that I will be checking to see if you're going to any other websites or anything, trying to cheat. I don't think you need to with the way that I give you all the information. Again, any problems, let me know. Technical issues, right? What do? Stop, text the professor, call the professor, let me know. Now, HESIs. HESIs are done on campus now. They used to do other things, but now completely on campus, all right? You only have one attempt, and it's 20% of your grade. I actually see in pediatrics, the mean is close to 900 through all classes in pediatrics, okay? So again, do what I tell you to do. You're going to do pretty good. We know remediation is mandatory, and there now is that personalized learning plan. I actually like it like that because it says 100%, you're done. Is it case studies? Is it hours? What is it? No, it's what it says 100%. So for the exams, make sure that you do have your extra ID. I've seen passports, I've seen campus IDs and driver's license. All of those will work. Again, talk to me. And now homework. Make sure you look at what's due on my information for week 2, and that'll be your assignments due. I mean, week 2, all you do is your discussion question, and your quiz. Now, late work cannot be accepted unless you tell me. Okay? I'm going to be late. Just let me know these things. Again, talk to me. NCLEX questions. NCLEX questions, make sure you follow what the guide tells you to do. For instance, this week, the first time that you take your NCLEX question, it is on growth and development. It's not under the section of pediatrics. It's growth and development, and you check infants, toddlers, preschool, school age, adolescents. If you send me the wrong pediatric NCLEX questions, you will see a 0 in your grade book. But in the comments, it's going to say you did the wrong list of questions. Do growth and development. Please submit by Sunday. No deduction. Okay? Now, don't send me that green box printout. I will not accept that. I need the 10-page or whatever page thing it is, because I need to look at the categories and things that you have chosen. Okay? If you do it wrong, I will give you a 0. I will send you instructions, and I will say, please submit by Sunday, no deduction. Okay? Again, make sure you have a minimum of 78 on all assignments that come in. Once you submit, you can't change them. I've had students at the end want to go back and redo NCLEX questions for a better grade because they needed it for their homework. I can't. All right? Please, always do your 78. You have 50 questions, you can do them over again till you want. On week 8 and week 10, we have these HESI assessment and practice exams. Take them seriously. They're really, really good for your HESI as practice, and they are through your Canvas shell. Your sim charts. I know when they came out, everybody was upset because you can't go right to the answers and answer them. You've got to read the scenario, so it takes time because you need the information from all that written scenario stuff. So take your time. They really have amazing information in them. On week 8, you have a pediatric assessment project. This pediatric assessment project is a diagnosis that can be pediatrics. You don't have to have a patient. It could be you. It could be your sister, your next door neighbor, your friend, somebody you saw in a hospital, or a diagnosis you want to know more about. Okay? It is 3 sections. What I ask you is don't wait till week 8 because community is going to have a big project. MedSurg has a huge exam and you're going to go crazy. All right? Do not wait. So, what I tell you to do, I know because of my experience that when you get to your BSN, it's all about papers, PowerPoints, and brochures. Okay? That's what a BSN is. So you need to know how to do APA properly. There's only a 250-word paper. Okay? If you do an APA formatted paper, send it to me before week 8. I will correct it, put it in proper APA form. So now you have a template for future papers on what and how to do a proper APA formatted paper. How does that sound? But you gotta get it to me before week 8. All right. I'll also work with you on the PowerPoint. Whatever you give me early, let me know and I can help you. All right. Again, it doesn't have to be a patient that you've seen. I like actually imagining making a patient up because now I got to figure out what assessment. What do they have? Do they have Ronchi or do they have stridor or do they have abdominal pain or it's all different. And then the treatment. How do I treat them? As we go further, I'll talk more about this pediatric assessment assignment. And I'm actually going to tell you those weeks that probably are the best weeks for you to attempt to try to get part of that paper done. There is a rubric. Remember, it's APA. There is Purdue OWL out there if you need it, all right? And then Dr. Brown puts these questions for thought here. She tries to correlate education into the nursing practice. If you don't get your assignment done, did you do that dressing to that patient in nursing? And these are the ways that she thinks about the way we grade and the way we look at students' assignments, etc. And it's true, if you're not going to do a proper job becoming your profession, how are you going to be when you're in the profession? And that's what those are all about. Any questions? So what's the big word with me? Communication. Talk to me. All right, let's do our PowerPoint for today. Again, all of this stuff is in your announcements. I always attach it there. And then I won't attach the rules on the second one, but I always reattach the Kahoots. I will be giving you that at the end. I don't give it in the beginning because I want to test you. If I give it to you before, you might know all the answers and you will get better deal from it. It's better to try to guess than to have it and memorize. So, Chapter 26. Now, one of the things as you go forward in nursing school, if that's what you want to do, they are going to be looking at you to do all sorts of projects on all different topics. And as a nursing student in school, it's like, what topic do I use? I don't know. Well, one of the first days in my BSN course, I was introduced to healthy people. And it was actually Healthy People 2010. It was a few years ago. But anyway, they're up to Healthy People 2030. And what this is government focus on certain conditions on healthcare disparities. Pediatrics is a healthcare disparity. They're young, they're immature, and they're a vulnerable population. Okay, we look at all of those different sort of things when we're taking care of children. Now, some of the big things that we know with health is obesity and type 2 diabetes. I mean, we're going to go into that more, but school age children tend to be not wanting to go outside anymore, whether it's the neighborhood, they can't, or they just want to be inside on their computers and tablets and phones and playing games. And, they're on screen time and they don't have time to run around and ride a bike like they did years ago. So they're getting bigger. Also, childhood injuries are there, violence. Vaping is that new big craze everybody's trying. And, if you don't think about mental health in children, but it can go from a bipolar, schizophrenic, and just depression. And it isn't just depression. Depression is a huge mental health problem. So, yes, I've seen all of these in children. Now, the World Health Organization, they like to look at infant mortality. So this is a term you need to know. A neonate. A neonate is an infant 28 days or less. So the first 28 days of life, you are a neonate. After that, up to 1-year-old, you're an infant. So just those terms I wanted you to know. Neonates, it's the bitsy baby, an infant up to age 1. What is very surprising, and you think United States is far ahead of healthcare, et cetera, we actually are not. We lag behind many, many countries. Switzerland, Norway, those are really different sort of numbers that we have. I look at when I first started into the newborn ICU. It was actually in 1983, a long time ago, okay? And I look at what the difference is the day that I walked out of newborn ICU. The differences are immense. The way they treat the children, the way they use equipment, the equipment that's used. I could go on and on and on, but we're still far behind and we need a lot more. We know the thing that will be in any problem is always that child that was born too early, that child that was born underweight. So it is that major determinant of death is that birth weight. How strong are they? Now, as we get older, birth rates go down. Okay. Number one, infants don't have their immune system built up. So now we're going to give all the immunizations. Oh, they're going to get sick. Now build up antibodies. And again, that decreases it. As we get older, again, our immune system's better. We're more alert. We understand. We know how to protect ourselves. We're not, taking some of these dangers that we would as a younger child. Now, as we get to be an adolescent, the big thing comes to injuries and homicide. Okay, they get to be a little bit careless. Whether it's picking up dad's gun, I'm a big boy now, I can hold it and it goes off, and it could go to that suicide. And as we get into adolescence in week 3, we're going to talk about adolescence. And one of the big things is body image. And if they don't like the way they look, mentally they're depressed, and that depression can and many times leads to suicide. So childhood mortality and morbidity, what's the type of groups? Well, those at high risk, right? These are those low birth weight that will always be in there. Of course, homeless, poverty. Why is children in daycare centers an increase in sickness and illness? So I'll tell you this a couple times this term. So put a kid in daycare. They're usually less than preschool, right? So less than age 3. So they're toddlers mostly. What do toddlers do and how do they explore the world? With their mouths. Toys, take up, roll around. Sensoria motor. It's the touch, it's the mouth, it's the movement. And then that toy, ooh, Freddie wants it, rips it out of his hand, puts it in his mouth. What do toddlers do all day long? They swap spit. Swapping spit, swapping germs. So that's why in daycare, children seem to be always getting sick, right? You know, pediatric nursing is a beautiful profession. Many nurses don't want to go into it. And the reason is the family, the mothers. They're very difficult at times to deal with. Now, they could be your best friend. They also can be your worst. Oh my goodness, she's coming in today. Anyway, we know as nurses, we need to respect that it is a family centered care. And we need to know that the family is the only constant in their life. They only know the family, their rituals, their foods, what they watch on TV, listen to music, what they drink, everything. All they know, the constant is that family. Pediatric nursing, there's many things that we have to remember. Children are fragile. And the one thing we know about children, every time they go to a doctor, what are we doing to children? Usually they're not sick. We're giving them a shot, right? So every time they see us, injection, they're hurting me, hurting me, hurting me. They're drawing blood. They're sticking things in my throat, up my nose, in my ear. This is all they feel. So what we need to provide is a different environment, okay? We need to minimize the stress and the physical harm, right? The physical that we would get. Now, when I was at the hospital where I worked for 25 years, I was going through school and I developed a program called Huggies. And it's an acronym, H period, U period, G period, etc. Help us give great injections efficiently and safely. Well, what I found is children were scared before you gave them the injection. Of course, during it, they're going to struggle to get up. And after it hurts, they needed mommy quick. So I decided, how about if mommy holds the child for an injection? Whether as an infant in the arms or on the lap. Of course, another nurse to assist holding so you don't jerk because mommy's not going to do that. And then we can give the injection in the arm, the leg, wherever it has to go. I did research on it on many age children. About 50 children was the end that I did. And what I found out was that children that were held in the mother's arms or the caregiver or the other nurse or whoever that were held, period, had less stress, fear, and anxiety before the injection and less stress, pain, and anxiety after it. And we knew that because it was evidenced by less crying. They didn't cry as much. So again, atraumatic care, do no harm. There's all different things. I think distraction is the big thing. The distraction was mommy hugging them and talking in their ears or whatever. And it works. We know nurses in family problems, especially if you work in a high level area where you see a lot of bad outcomes and or children dying or very sick, going through big, sort of hospitalizations. You're not only going to be with that child, it's also the mother. Also, you're going to see problems with mothers and fathers and mothers and grandmoms and aunts. And all of this is going on around this child again. You have to advocate for the child and for the family, and it is exhausting mentally some days, but it's also extremely rewarding. During this time that we're taking care of children, from the moment I meet a child, remember, you're doing your discharge teaching, health teaching from the moment you get there with them. And one of the big things in pediatrics is injury, safety protection, right? And infection control. Those things you always need to be thinking about. Yeah, we're the counselor. Absolutely. I've seen so many parents break up. I've seen parents get stronger. I've seen families break apart. I've seen them get stronger. So all that happens. So the leading cause of death among African American boys ages 15 to 19 is which one? Leading cause.
C.
Firearms. Yes, it is. Thank you. Thank goodness it isn't suicide, please. Woo. So let's go into culture and religion. Now, first of all, I want to say this. You do not have to understand or agree with another religion that's not yours. You only have to know who you are, your religion. But as a nurse, you must give that family, that child, that opportunity to practice their religion as long as it doesn't interfere with the medical care. Okay? You don't have to agree. I mean, I know what I know. You know what you know. I just have to say, okay, it's good for you. I have mine, you have yours. All right, what do I need to do? How can I help you? Period. Family, we know it's the only constant in their life, right? But what are families? Oh, there's so many types. There's two moms, there's two dads, there's a mom, there's a dad, there's, grandparents, there's adoptive parents, et cetera, et cetera, et cetera, et cetera, right? All sorts of families. The family is whatever they say it is, okay? We know that each family has strengths and vulnerabilities, and we know that there's always that one person in control. I know when I moved to Miami and got involved in the Hispanic population, I had to realize many times that person who was in charge was grandma, abuela. I mean, grandma's the one that you listen to. So I had to realize that. But of course, you got to get permission from mom because that is the HIPAA, et cetera, et cetera. Okay. So again, knowing those sort of things, you can get information and quicker and better take care of that child. We know adoptive children, there's all sorts of things that goes on with them, all types of children. Again, I think TB is one of the biggest things that comes, migrant workers, and it's one of the big concerns on bringing from out of the country. All sorts of parenting. Do I have to say any more? Single parents, working parents, foster parents, et cetera, et cetera. There's so many. Now, what do we need to know about this family? Well, we need to know, for instance, you get some of these cultures or religions, they don't eat meat. They're vegetarian. They don't eat beef. They don't eat pork. I mean, there's all different things. Now, how do I know these things? It's because I've asked the parents or I've asked that child if they're old enough. What are certain things I need to know? For you have a problem with diet, or sometimes it's the caregiver. They don't want a male with a female patient or a female with a male patient. There's all different things that I'm telling you is asking the parent is how we get these sort of things done. We know there's everything that can affect a family, but our job is to get that child calm, cool, collective, and the family, calm, cool, collective, and then work a path on getting that child better and out of the house, out of the hospital, back home at the house. So a frequent health problem of migrant children and adolescents in the United States is it's actually TB. We as Americans do TB testing all the time. We do, but they don't in foreign countries. Now, let me tell you a little story about that. I was working in an emergency room, a very, very, very busy emergency room, pediatric emergency room. And I worked triage a lot. And it was busy. It was packed, you can imagine. And the line was out the door for patients coming in. And this woman came up to the desk with a small child, about 13, 14 months, and said, he's sick. I need to see a nurse. And she was trying to speak English. And you could see that she was a migrant worker from Mexican. You could tell because she had other kids there. Oh, they're always so clean and neat. She had her little bag of snacks with her. You just know, you could tell. So she came in, brought her back when I heard this going on. And I looked at this child. I said, so what's going on? She had already been to her health provider or that health person in that migrant camp, which that's the person that would treat sicknesses in that camp. Not real doctors, not real nurses, but somebody who was, taking care of them. And the child wasn't getting better. When I looked at the child, his cheeks were bright red, ears were bright red. I'm like, oh, we have a fever. It was 105.6 axillary. And I'm like, oh my goodness. Well, the child ended up with TB and bilateral pneumonia. Now, I put a mask on when I saw her and I saw the condition of the child. But can you imagine as a nurse? These are things you need to be aware of and think of. A migrant worker, they should work too, but again, protecting yourself. And then of course I put this child in a reverse flow room, and the child actually was admitted and actually did well. I went up to see that child in the hospital. So genetic influences, when you think of genetics, you think of how they grow, right? Think about this. I think this is mind-boggling. A baby is born at 7 pounds. They can't even lift their head. They don't even know how to breathe. And what do? We smack their butt, they take a breath, and we stick a nipple or a bottle in their mouth, right? And now you have to suck, swallow, and breathe. They didn't know how to do that 2 seconds ago, all right? That's 7 pounds birth. At 6 months, they've grown 6 inches, and they've doubled their weight. Is that crazy? And by 1 year, they have tripled their weight and they're up and walking or attempting to walk. That's 1 year of life. So the growth, development, maturation, differentiation is interrelated, simultaneous, and ongoing. They lift their head, they turn over, they roll over, they get on their knees and they crawl, they creep and they walk. It's amazing. So, patterns of growth and development. So, directional, we know is head to toe. We start lifting our head. Cephalocaudal. Remember, cephalic is another word for head. Cephalocaudal, head to toe. Start lifting the head and up on their feet, walking. Sequential trend is again lifting the head first, rolling over, then crawling and creeping and walking. Okay, there's a sequence. Now, it doesn't mean they don't have to skip a sequence. Believe it or not, I have an 11-month-old grandson who's in his walker, standing up and can like run with that little bit of support. Doesn't walk normally. The kid doesn't crawl. He doesn't want to. He's lazy. But this kid is so active and he's running with his walker. So it doesn't mean he's mentally behind. He skipped a step. He's moving forward, though. That's what you look for. Now, those sensitive periods are when these children, they're at that area where they're very, very sensitive to learning things that are going on around them. So, infants are neonates when they're born. As a neonate, normal heart rate at birth, 140 to 160. That's pretty good, huh? It's high. Respiratory rate, 40 to 60 at birth. And a normal blood pressure for a normal newborn is 60 over 40. By 1 year old, their heart rate is 100 to 120, respiratory rate is 20 to 30, and blood pressure is 80 over 60. Do you see how the metabolism, number one, at birth, they don't regulate their temperature. By 1 year old, they can run around naked, all right? Their heart rate comes down, respiratory rate comes down, blood pressure goes up. Their sleep and rest, they're sleeping a lot as newborns. As they get older, their sleep schedules is a lot less, usually through the night and a nap or two a day, if you're lucky. And you're going to hear me say this over and over. Nutrition, nutrition, nutrition. If you don't put gas in the car, does it go? No. If you don't feed the tank, they're not cognitively going to be where they need to be because they need that fat and they need those vitamins and minerals for the brain to grow. All right. And you want to see them getting bigger. Why do you think we do weights and heights on every visit of a child? We're making sure that you put enough gas in the tank. And if you put too much gas in the tank, we need to slow down that tank, right? Less putting in there. Again, nutrition, nutrition. How do we measure nutrition? Growth, which is height and weight. It's also cognition here. Are they alert? Are they where they need to be? We know there's all sorts of children that we can see, the kid that goes to anybody, the kid that's never satisfied, and the kid that just looks at you in the side of his eye and eventually will go up to you. We know there's all sorts of temperaments in children. You've got the good kid, the one that's crazy, and the one that nobody can hold, right? But they're all different. And that's what makes children so wonderful. Now, in the first exam, you're going to see about 7 questions on theorists. I'm going to repeat this about 4 times before your exam, and hopefully you can also go through it and try to understand it. Let me try to explain it in a manner that you can understand. So, Freud. Freud is a theorist who says everything about this child is related to sex. Whether it's in the mouth, whether it's anal, which is potty training, phallic, they find and figure out what they got there. Latency, I'll tell you at another time. And of course, adolescents are all about the hormones and getting with a person, right? The genital stage. So that's Freud, anything sexual. Erickson talks about any person who reacts with that child, all right? That child, even as an infant, we know that a child as an infant, do they react with the people around them? They do. When do they react? I'm dirty, I'm hungry, or I hear you, I want to go out there, right? Excuse me, my husband's trying to call somebody. All right, got it. Sorry, I apologize. So, infants are calling out to the people around them, right? Why? When that person goes, mom, dad, grandma, whoever, caregiver, nanny, always goes and picks up that child, they trust that when they cry or coo or make noise or whatever it is, they know somebody's going to come get them. They're happy, healthy, bubbly, sweet children because their needs are met. They trust. Now, there are situations, maybe in abuse, alcohol, drug abuse, something where that child is not as picked up as much as it should. Not one time, but most of the time. This is a child that we say is mistrust. They usually actually get to the point where they stop crying. And actually, you could see them like they're just disinterested. They don't trust. They're like, whatever, and that's sort of pretty sad. So anyway, and we'll go into the rest of them, how the child reacts to the environment. Now, Piaget is all about the thinking. Remember I said the baby is born, they don't know how to breathe. Spank their butt, they breathe. All right, now they know it. I can do that now on my own. Now they breathe. Then you put a nipple in their mouth and they're like, huh? And then they figure out, they suck on it and they go, oh, now what do I do with it? Oh, and then they swallow. Now they've learned to suck, swallow, and breathe. This is Piaget. Piaget says there is a progression or schemas that happens that creates learning and the brain to get smarter. Initially, a baby with a reflex will grasp, let's say, mommy's finger. It's a reflex. They go, oh, okay. Eventually they say, oh, I like that. Let me try that by myself. No, that's not a reflex. Now they grasp that rattle. Oh, that's the schema. We started out with a reflex on mommy. I liked it. And now I've got the rattle in my hand. And then they move the rattle and it makes noise. So next time they get the rattle, they shake it because they know it makes noise. Oh, it falls in the mouth. Nom, 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 nom. Oh, I like that too. Next time they get the rattle, they grab it, they shake it, they put it in their mouth. Do you see how they learn? From little things, they build up to the big things. And we're going to go over it. And Piaget says the first 2 years of life is all about sensoria motor, sense, touch, ori, mouth, motor, moving it around. Okay? That's what Piaget says. How I think, how smart I get. So cognitive development, as I said, is exactly what I just said. They're born in an environment, they learn how to speak, and they learn how to do what they need to do, and they build it upon that, like stimulation with mom and dad and the playtime and all that stuff. All that stuff helps with the growth of that brain. Now, the other theorist is all about moralities, which is right, wrong, okay? Moral development we usually discover it as right and wrong and the consequence of each. I think preschoolers that age, what we describe, the Kohlberg, is reward and punishment. I do something good, I'm getting a reward, a praise, a hug, or candy, or I'm going to get a punishment, timeout, lose screen time, TV, whatever, right? Reward, punishment. Now, let's go into play. Did you ever think play would be so important? What do children do from the moment they wake up to the time they go to sleep besides eating? They're playing, aren't they? They always have something in their hands, looking at something. It could be their hands, it could be the blanket, it could be anything. They're playing, playing, playing. And this helps with cognitive development. That's why we encourage play. There's different names of play. Socioaffective, which means they're in a group. Sense pleasure. This is what mashed potatoes on that high chair, let them smush it everywhere and all over their head. It's like that touch, it's that feel. It could be sand in a beach. I mean, could be anything that's smushing the fingers. They need to do that. Sensorial motor. That one can't go in the mouth if it's sand, but mashed potatoes can, right? Skill play. This could be taking and clicking things together or putting a block on each other. Unoccupied play with nobody. Dramatic or pretend play. We use these sort of things, the dramatic. We could do this to reenact experiences, whether good or bad, okay? We can do that in the hospital. We've done that also, dramatic play. And of course, there's games. What does play do? Well, it's sensory-motor development, right? And what does sensory motor development do? It promotes intelligence. They get creative. They put things on top and things and dress them, and they do all crazy things. But in their mind, they're having fun. They're playing. Their imagination's going, and they're having a good time. And that's what you want. You want to stimulate that brain from all these things. So, types of play, and these you need to know the differences. Onlooker play, you're looking. Solitary is alone. Now, the next three plays are important. Parallel play is preschoolers. Parallel, PP, preschoolers. What do preschoolers do with their play? Excuse me, I'm absolutely wrong. Parallel play is toddlers. I'm sorry. TP, toilet paper. TP, toddlers. These children play next to each other. Two or more kids. They're playing around each other, but they do not share. Toddlers are me, mine, I'm not sharing. That is a normal toddler. That is parallel play. Kids playing next to each other, no sharing. Associative play is preschoolers. That is your pa, all right? This is kids, two or more, playing together, sharing the toys and having a good old time all together. Just playing. Cooperative play is your school age. Now, two or more kids playing together, but it's not just play. There's something that's being created or something's built. There's a goal. Somebody wins the game. The train track is completed. The sandcastle is made. The house with the Legos is done. Whatever it is, there's a goal. There's an end. Associative play is just play. There's nothing created. There's no winner. Cooperative play, the older kid can create and make something. And that's what they do. Toys. Toys. How many toys do we need for an infant, right? I say give them a paper box and a crunkly bag, and that's all they need because they just need something to touch and feel and to learn with. Now, what we use these toys for is, that's mom and dad a lot of times on the floor with them, and they're taking the toys in front of them and they're using their muscles to try to creep and help make those muscles go. My newest grandson, Benjamin, you put him on his tummy, he goes flat on his tummy, puts his head down, goes, wah! We're like, okay, you're still going to stay there. You get up on your knees and start crawling. But anyway, pushing, pulling, rolling all over. This is all with the muscles and getting them. Because remember, in 1 year, they're walking from not even lifting a head. So they've got to really work these muscles. So developmental assessments. Doing pediatrics and adults, there's a difference in the way that we assess children. Children is not usually head to toe. You can't just do a head to toe. Number one, most kids will not tolerate it. They've short attention spans. Plus, you're a bad person. All you do is give me shots and hurt me. So they're not going to want to sit for it. So what I say with children and what even the book says, it's not head to toe. Do a focused. If it's child's coming in with a cough, you're going to listen to breath sounds first, or do an O2 saturation first. So again, and then slowly, if need be, do the rest of that assessment. Okay. There's several things with children that are different than adults. Is how you approach that child. Now, I am not a little girl. I'm over 200 pounds. I'm 5'8". I walk in that room and children can be extremely scared of me. So what do? I immediately get it on a chair and I actually sit a little bit below them. And now on their developmental level, I start talking and playing with them. I would always have stickers in my pockets. SpongeBob, princesses, Spider-Man, whoever. And I'd say, so which one do you think you'd like today? And then I was going to start, now I got to do vital signs. How am I going to do that on a kid who's scared to death? We're going to make play out of it. He's going to play, he's going to push buttons with me, and we're going to have fun with it. So how do we approach children? Get down on their level and be on their developmental level. Now, genetic things that go on are many. It could be from, a cleft foot or missing a foot finger, an arm, a leg. I've seen all of those things. Or it could be that genetic like Down syndrome. Here are some of those syndromes you could use for your project. Down syndrome, Prader-Willi, Turner. There's a lot more on your week 8 modules, but you don't have to use that. You can find anyone you want. I actually had a couple diagnoses that I had not seen before done last term, and I love that. So genetics, big thing. Our role is, if we don't know, ask. And if parents are having a child that have genetic issues, we should always encourage them in genetic testing. And of course, these children, as a nurse, making sure they get all what they need to take care of that child in the home. So communication. One of the things with pediatrics is at 18, an awake, alert, cognitively normal child can sign their own consent. And you need their permission to ask for the mother and the father to understand the information that they're telling you. Can I talk in front of your mother and father? So be very careful in pediatrics when you have older kids, because you can go against HIPAA by giving a parent information on an 18-year-old because they are in charge of their own care. Communicating with parents. Well, you want a parent to talk and tell you what's going on. I mean, many times, parents are so nervous and scared and concerned that they're going to start with a dissertation from the moment they got pregnant up to the point 9 or 10 years later, how old the child is now. Just redirect it. What's going on with the child now? It's a normal type delivery, etc., with no conditions going on. What's going on now? Another thing, and I didn't understand this till I moved from a really small town in New York to Miami, is that you've got to be aware of cultural differences around you. There are some cultures you can't look at them in the eye. There are some cultures that don't like to be touched. I'm a hugger, I'm a toucher. I mean, that's who I am. I've had to learn differently. So how did I learn? I asked the parents. I asked the child. They like that respect instead of guessing. All right. They really, really do. And actually, they put you up on a notch because now they're okay. She's asking questions. She's a safe nurse. Okay. Always ask that question. Remember, using silence, not always in between them talking. Give them the time to get it out. And then I always, especially when I see a mother or father or grandmother, whoever, who looks exhausted with a child who's sick, who's been dealing with a sick child for 3 or 4 days, who's working and 6 other kids at home and whatever, be empathetic and tell them, Oh, wow, you've been through a lot. Oh, but you've done a great job. You're here now. Let me take care of you. Can I get you a cup of coffee? Or would you like to go get a cup of coffee? I'll watch your child for you. I mean, those little things mean a lot, and that makes them listen more to you. And that avoids any roadblocks in communication at all. And remember, an interpreter can't be a family member. It must be through either a professional that you work with or that blue phone or whatever it is that you have. So again, communicating children, you got to be careful on where are they on their growth and development process. An infant, you're not going to give a sticker and go to work, but you might have a little rattle and shake it, or you might make a little noise and it'll touch them a little belly and go, 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 go. That's, again, what is, and you're not going to go cuckoo coo to an adolescent. So again, knowing what you need to do to be able to communicate. As you're doing your assessment for your child, let's say they're being admitted to your hospital and you are the nurse. Number one, make sure you know who's the informant. Is it the parent, or do I need the grandmother in here with me? This is something that you're going to make that determination. What's the chief complaint today? Why are they here? And what are the symptoms that they're going through? Birth history, just to know if they were hospitalized. And then dietary. Are they vegetarian? Are they allergic to bananas? Are they allergic to nuts? Very important. And that's part of allergies too. Any other past medical history? And any medications that they're on, especially if they're on antipyretics, when they last take it so I can give them the next dose. And then immunizations. If I have a young child in less than a year old that has upper respiratory mucus, low grade fever, and has had no immunizations, this child cannot be placed in another room. They must be put in a private room, and I'm putting a mask on right away. It could be pertussis. You don't know. So again, immunization status, very important for you and for your other children that you're taking care of. Knowing their growth and development is like Benjamin. If we took him to a hospital, we'd say, he don't crawl, but he walks almost. He's in his little walker, like doing 100 miles an hour. And then any habits, favorite blanket, favorite binky, favorite toy, whatever. If the parent leaves, I want to know how to comfort that child. Performing a health history, depends on the age, but let's say it's that older child, the adolescent. Remember, we can ask parents to leave the room to get information from an adolescent, to give them the opportunity to be able to tell us, yeah, I have all these urinary tract infections because I've been having sex. And then you can give information. Well, you're not supposed to have sex, but if you are, well, if you urinate right after you have sex, it's been shown to decrease the amount of urinary tract infections. How do you wipe yourself? How do you clean yourself? These things could prevent another infection. Now, do I have to tell the mother? No. Only if what she is telling me is going to harm herself or others. But I've helped the child, right? I've helped her try to hopefully be better. One of the things that I do sitting down, especially for young kids, to think about how they're going to be responding to me and how helpful, I'm going to ask them about school. How is school? What grades do you get? Who's your teacher? What's your favorite subject? And you can tell by the way they answer how helpful they'll be. So then I can go into an explanation and they could work with me as my buddy to help do a blood pressure or do whatever I need to do. Those unusual habits, anything, good habits, bad habits, good things, we need to know about it. Another thing that I look at is a parent-child relationship. There's some parents that are very close to their kids, and there's some that I can walk into a room, parents on a phone, the kid standing up on the bed, trying to reach for something, throwing things all over, going into drawers, and I'm like, excuse me, can we get this stuff picked up? Oh, come here, let's help me. Come over here and help me pick this stuff up. And that you can see that that parent really doesn't have a good control on that child. Dietary, as I said, cultural, we want to know. Also, cultural if they're vegetarian. What would be a big concern about a patient, a child, being a vegetarian? We'd be concerned about iron deficient anemia, right? So, number one would be monitoring that CBC when we do that lab work. And we would encourage maybe a dietary consult, right? They may be given different foods that they could eat that are higher in proteins that could help the child, and of course, the parents too. So, again, using food in order to help with conditions, you're going to see this all through this course. Again, iron deficient, let's give more protein in there, give more iron. Again, the sequence of examination, we're not doing head to toe. We usually do, as I said, a focus from there and that preparation of the child. Minimize the stress and anxiety by getting them understood what's going to happen, putting them in mommy's lap, giving them the comfort, and don't lie. These children remember. You know, you think young kids forget when you tell them something, oh, it's not going to hurt, you'll be fine, and it hurts, they're not going to forget you. And you're never going to have that same relationship again because they're not going to forget you lied again to them. So, again, get a good relationship, be honest, and of course, have somebody there to give that hug and that love that they need, which does decrease all that anxiety. So, again, let them know what's going on, have the parents there. Remember, it's always on their developmental level, and then let them know if they're going to be in a certain laying down position. Like if they're having a spinal tap, tell them how they're going to be, that you're laying on their side. And then I usually will give them a hug behind their neck and underneath their knees. And I'm going to sit there and hug them, and I'm going to talk to them the whole way through. And you're going to feel this, and that. These children do really well if they know what's going on, because if they don't, they're going to move. So, which approach would be best to use to ensure a positive response from a toddler? A toddler, ages 1 to 3. What's the first thing we do when we walk into the room of a young child so that we don't look like these big, booming people that are horrible that's going to attack?
A.
Absolutely. We're going to get down on their level and we're going to talk quietly. We're not going to be talking loud. No, quietly. How are you doing today, Derek? I mean, whatever. Oops, sorry. So, doing this assessment, there's all different things. Usually, when we have newborn infants, every single assessment, first thing you walk into your initial assessment, you're always going to do head circumference, usually abdominal circumference, usually length, making sure what's going on. When do you think we can start feeling a radial pulse on a child? Because usually they say it's an apical pulse. Up to age 2, you should be doing apical pulse for full minute. At age 2, you can do a radial pulse. So we know more accurate, yes, it's going to be apical depending on why you're doing it. Counting respirations and then blood pressure cuffs. We've got all sorts of blood pressure cuffs. Some of them can fit on my little pinky all the way up to my extra large adult for me. Looking at them, children you can look at. Are they well appearing or are they sick? When you look at them, you can tell. Sometimes it's the color, sometimes the way that they're holding their body. As we're looking at them, lymph nodes, you should not see them if they're well. Lymph nodes are there to protect the body for infection, right? So they get big and bulky so they can provide the infection protection that they need, right? Once you're well, lymph nodes are flat. You don't see them. They're gone, all right? Looking at the rest, abdomens are a big thing in young kids. We always worry about digestion and the food going down. So we look at it, inspect it, auscultate it, palpate it. Genitalia. I've seen ambiguous genitalia. We'll talk about that more in week 7, I think, about that going on with the adrenal glands. I've also seen something I didn't know about, which was called the labia were fused almost the entire way on girls. One was 8 months, one was 15 months. It's like 3 or 4 in my career. And all they do is put hormone cream on it and it just goes back. But the interesting thing about that is now I have to do a catheter, a urine catheter to get a, good specimen on them. Now that's a hard thing when you can't see anything, right? It's sort of, oh, I think it's about there. So, and we're looking, how about anus? Why are we looking for an anus? Everybody has an anus, right? There are times when no anus is formed at birth, okay? Why do you think you do a rectal temp when the baby is born? To check the temperature? Yeah. But also to make sure there's an anus there because we need an exit for that, whatever, secretions are going through. You're going to look at the back, making sure there's no dimples. There could be problems with the spinal cord, maybe a myelomeningocele, things coming out, or that dimple going on. Looking at the joints, the muscles. We're going to be looking at the way they reflexes, are they have the startle reflex when they jump, or you stroke their cheek and they're going for the bottle of a moral reflex. These are things that we'll be looking at. This is where we do the head circumference, chest, and the abdominal circumference. Head circumference, why do we do them? Well, at birth, a baby is born with 2 soft spots, fontanelles, one on the top, anterior fontanelle, and one in the back, posterior fontanelle. The one in the back is gone between 2 to 3 months. It's gone. So it's closed. So all we have is this one on top till about 15 months. Okay, that's the anterior fontanelle does not close till about 15 months. We measure the head circumference to monitor for fluid, hydrocephalus, to make sure there's no swelling going on. We don't know if that cerebral spinal column and that fluid is going up and down the way it should. We measure it closely. Why do we measure abdominal circumferences? Well, we measure that to make sure the food's being digested. That's one of the big ways. If it's soft, it's flat, it's not increasing in girth, the food has gone down. So those are some of those. Another thing we do on every child when we see them is we do a height. Again, we're monitoring, are they getting the nutrition? We're also monitoring some hormones in there too. But anyway, we're monitoring nutrition. We'll talk about that now. Now, that little girl is underneath this board on her head. You know how many toddlers want to scream and yell and run out of the room because they think that board's going to come down and pop them on their head. So what do? I make it into a game. I said, let me show you what we're going to do next. And I stand up top and I put that board here and I go, oh, let me hold it and go tap, tap, tap till I feel it. Tap, tap. Oh, there it is. And then there was like a little number on the side with your height. I said, oh, look at my numbers. I'm a 6 and an 8. Oh, let's see what you are. Put the little kid behind it. Do your tap, tap, tap. What number are you? She just got her height with this big board. It could have slapped her in the head. It took me 1 extra minute. I got what I needed and I got it accurately. Again, children, I went to work every day and I got to play. Isn't that fun? Blood pressure cuffs. We can do it anywhere, right? We can do it in the arm, upper arm, lower arm, upper leg, lower leg. I want you to know the truth in me. On toddlers, preschoolers, they had D. I'd put it on their lower leg because it's less, it doesn't hurt as much. It doesn't pinch as much. I know the one in the upper arm, I don't like it on me. It pinches. So I do it on the lower leg. I distract them. They push the buttons on the electronic machine. Life is good. All right, and then the last topic of today is pain. This is part of why I did my dissertation. School-age children's attitude and behavior towards children, towards injections. Now, injections are, this needle, it's this pain. Why are they afraid of them? So that helps me, right? We know that children are, and it's one of the things that I've seen in my career, they continue to suffer from inadequately treated pain, whether the child is afraid to ask for it because they don't want the shot, they don't want the liquid, they just don't want to ask, or they don't know they can ask, or the parents are telling them, no, you don't need it, so don't ask for it. All of those things. We know that nurses don't consistently treat it around the clock like we would do maybe with an older patient. Or we give them less than that we're supposed to because we think it's just too much morphine that's been ordered. And we know these doses so well. This is an old drug. We've used it for so many years. We know the doses well. And we know that following them up, did we evaluate the effectiveness of the pain treatment that we give? And remember, pain treatment is just not the medicine. It's also doing other things, positionings, ice packs, cold packs, a rub, a massage, putting on a movie, sitting down, playing a game of cards with them. So many things could do that, distract. So we've got to evaluate what is the pain. We know in adults, 0 to 10, 0 is no pain, 10 is the worst pain in the world. How do you say to it, hey, my little newborn infant, so are you in pain? What number are you today? Well, it doesn't happen. So we've developed different scales. There are 3 scales you need to know. FLAC. FLAC measures the facial expression. Are they grimacing? Leg movement. Are they like pushing up and down like their tummy hurts really bad? Activity. Are they laying still, afraid to move? Crying. Tears, real tears, and can you console that cry? All of that will give you a number and we'll evaluate, yes, you need to give something for pain and you need to do more than that. The other scale is a Wongs-Baker Faces. I put one of them there. They look all different. Some are 0, 2, 4, 6, 8, 10. They're all different types, all different faces, but they are something that the child can look to and relate. They can look, and it's so neat. Get a little 2-year-old child who's, let's say, has an earache really bad, and you tell them the scale, how much does your ear hurt? And I'd say, this is nothing. You don't hurt at all. And this one's really, really, really horrible. And they'll point to a number and you're like, and up to a 6, not a 10, like every adult would say. They'll give you a number, and it's sad to watch. But this FACES scale is used from ages 3, and you can use it for the rest of life if you want, but from age 3. FLAC scale, 0 up to age 3, and also nonverbal children. It could be an 18-year-old girl with cerebral palsy that doesn't talk. We can still use a FLAC on her, okay? And remember, there might be different scales at your hospital, but those 3, numeric, FLAC, and FACES. So FACES, again, your pain scale has to be appropriate for the developmental level of your child. If they can't talk, you need to evaluate. That's a FLAC. If they are 3 years and older, we can do the FACES. Point to what you hurt like. 8, 0 to 10, like we do with adults. And that would be your numeric scale. There's all sorts of pains out there. We know that pain that you have all the time, it can really affect. I mean, don't think just adults, old people have chronic pain. Young children can have pain. Think about sickle cell disease. Think about rheumatoid arthritis. Think about these things. There's always in pain with these children, and it does affect everything. So trying to get that child as managed as well as possible and educate that child is what we need to do. As I said, there's other sorts of checklists out there. Whatever the hospital has, use it. Just know that there are some that can be there. Managing pain, it's not just the drugs, right? It's also that distraction. I worked night shift for about 23 years of my career. The last part of night shift, I worked in the cardiac ICU and the newborn ICU. And at night, every room had a radio. And I'd go put on a mellow rock, all right? 102.7 magic. And it was just a very light music going on, and it'd be in the air. These children slept all night long when I was there. When these children went home, the parents used to tell me they had to play music because it was so comforting for them. Okay, that was one distraction I used just globally. What else? Sickle cell, ice packs, hot packs. What do you like? I just had my tummy did surgery, elevating the head of the bed, bending my knees, getting a pillow. All of these are distraction. In children, giving them an iPad, giving some crayons, a piece of paper, anything can get a kid distracted. Again, those things work good. One of the things in pain management that when I was doing my research, it had me think, and it was about a pacifier with a little sugar water on it called a non-nutritive sucking with sucrose. Okay. Well, there was a research done from Harvard neurophysiologist, and it looked at morphine and a pacifier with sugar water on used for circumcisions in infants. They found that there was no difference between morphine or the pacifier with sugar. So, what is that telling you? Anytime we need to do a procedure on a young child with a pacifier, put a little sugar water on it and they suck on it, and the pain is much less decreased. My grandson, my first grandson, this was 9 years ago now, but he had a circumcision in the office with a pacifier. He cried because they laid him down and strapped him in this device. But when they gave him the pacifier, he calmed down. And then he never cried again. It's amazing that it works. We use pacifiers for blood draws, catheters, anything with children. It does calm them. Remember, they find the world, they explore the world in their mouth, and this is the stress reliever right here. My husband calls a pacifier a soother, and I think it's the perfect word for it. There's not just morphine out there or Dilaudid or any of those things. Remember, there's acetaminophen, there's ibuprofen. Using that in between the narcotics gives this child full coverage, okay? At times, older kids can get the PCA pumps, the one that they can pump their own narcotics. It is a great alternative for pain management with these children because you can program in how much and how often they can get it. It could be really safe. So it's something that we do use. Some else things that we use, how about putting numbing cream on things that's going to get a needle in it? Why is that girl smiling? She's getting her blood drawn. That is a numbing cream that was put on her anti-cube. So she knows she's going to feel touch, but she's not going to feel any pain. So she's happy. So we're using that. We use that for lumbar punctures. We use that for stitching. We use that for putting teeth back in the mouth. Any numbing cream anywhere we can use, we're going to use it. Kids hurt everywhere. I don't have to name all of them. I think the biggest pain site in children starts at immunizations, right? Immunizations, we can do a lot of things to help with it. And again, it should be teaching, about how to pedal the legs afterwards, maybe putting coolness on it before we give it. Whatever it is, we could do a lot of things for it. But children do hurt, and they do hurt for real. So, which of the following is an important factor for consideration in understanding the pain experienced in children?
B.
Right. They're not going to admit, are they? Why? Because they don't want that stick, right? They don't want that pain. Okay. I'm going to go straight through to the Kahoots, and we're going to be out about 20 minutes early. Is that okay for all of you? Or do you feel like you need a break? What would you like?
Oh, we can for sure do the Cahoots.
We can do it.
All right, here we go. Do you all know how to get into the Kahoots? Take your phones and put it on that little code there, and it will go to kahoot.it, and you go directly to your game. I want you to know that you don't have to be afraid about your names put up there. I don't look at the Cahoots results. I don't look at who got what right, what wrong. This is your, this is for you. I don't do these for me. This is for you to test the knowledge and concepts I just gave you. I don't monitor this. Okay? Some students think that I look at how many students and what. No, no, this is yours. I want you to use it as a study guide. Somebody want to win today? I think Victoria does. I can see that rate in you. How about
Could
you,
we take
Cheryl?
a little break before the Kahoot so I can make like another drink and stuff?
You want 5 minutes?
Yeah,
I can do
please.
5 minutes. Come at 3:50, 5 minutes. And I'll go to the ladies' room myself. Perfect. Is everybody refilled and refreshed and feel better?
Yes, thank you. I was so thirsty.
That's not a problem. I'll go straight through and get you out early. It's usually what's requested, but at any time something comes up, I'm here to help. All right, let's get going. Let's see if we can get a Cheryl or a Victoria or a Jade or a Brittany or somebody. Who's going to do it? Whoop, whoop, whoop. I think it's only 33. We're good today. The leading cause of death from unintentional injuries in children is. I hit you with this question first because you're going to see this in so many types of questions. So children, all ages, what would affect all ages? All ages of all of these, the only thing is motor vehicle related. Whether they're in it the wrong way, not strapped in it, not in the booster, in the front seat, front facing, rear facing, motor vehicle related. And then adolescents are driving. So that's all about the injuries, motor vehicles. Which statement is most descriptive of pediatric family-centered care? What is family-centered care? What are the family? And the family is the only constant in their life. We don't realize or think about it, but as we're young children, the only thing we understand is what our family does. We don't understand other families' cultures and what do they do, their things. And it's as we get older, our minds are brought up to the whole world, what's happening out there. The major cause of death for children older than 1 year old is what? Children older than 1, so you're talking about a toddler, and toddlers are the explorers, and it's all about those unintentional injuries. It's jumping off of the couch and trying to get to the other chair, missing and hitting the head on the floor of a concrete building, right? This is what children do if we're not careful. The nurse caring for the child in pain understands that distraction. So remember, in distraction, in anything that works with children, the first thing you need to remember is it must be developmentally appropriate, because that's the only way that you can refocus that attraction. I'll give you an example. Would I give an infant a sticker? Is that going to help that infant? No. If I gave it to a toddler, yes. I give an infant a rattle and he shakes it. Oh, now I've distracted you. It must be developmentally appropriate. And remember, you got to get down on their level. That's the first two things. Multiple questions on those things, okay? Very big concept, how to deal with kids. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? They're all going to play together, but they don't make anything. Nobody wins. No goal, but they're playing, they're having a good time. So remember, no goal. This is associative. Remember, preschoolers are playing all together, but they don't know how to do a goal yet. They don't know how to make something win. Okay. So that is no goal. Which statement best describes the process of critical thinking? Do you remember in orientation, the dean told you that you're going to have to learn how to critically think? And all of you go, oh, gee, what does critical thinking mean? Oh, my goodness, do I know how to do it? Well, think about Have you thought about what you're having for dinner yet? Did you think, are you going to buy it? Are you going to, a takeout, or do you need to go to the store? And what do you need from the store? That's all critical thinking. That's all what nursing is putting the pieces of the pie together. It's purposeful and it's goal directed. What is my goal? I want dinner. How am I going to get there? I need to go through this process to figure out the best way to make my dinner, which is my goal. Okay? Goal directed. Simple as that. Which is probably the single most important influence on growth at all stages of development, from infant to the old to the elderly. Nutrition, 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 nutrition. Yeah, culture affects, your growth. Yes, but if you don't put fuel in the tank, it doesn't matter what your culture is. Okay? Nutrition. Which function of play is a major component of play at all ages? What's play all about? What does it do? So, the sensorimotor activity promotes creativity, socialization, and intellectual development. It's all about that touching in the mouth because they explore the world in their mouth and moving it around. Sensorimotor. That's what play is all about. It promotes all the other stuff. How do you apply nystatin to an infant with thrush? Now, there are some differences in the adult world and the world of a child. This is one thing. Nystatin in an adult, you swish and swallow, right? That's that yeast, that fungus on the mouth. So how do we do it in an infant? Do they swish and swallow? No, they don't. What we need to do, and this would be in a different type of approach to care, we take a little cotton swab and just take where that little white is, smush it all over. You don't have to swish swallow type thing. It doesn't work. So as we go on, you're going to see the differences between adults and children and the different type of practice changes. 3 children playing a board game would be an example of what? What's a board game? Checkers, chess, Trouble, Candyland, Chutes and Ladders. Remember, a board game, there is a goal in the end, and it's 2 or more children. This is 3 children playing a board game, which means somebody's going to win. That's cooperative play. That's school-age children usually. The head to tail growth, direction of growth is referred to as what? Head to tail. Look at the words. It's cephalocaudal. Remember, cephalic is head, so cephalocaudal. Proximal distal is when they start here, knowing their environment here, and then they start going distally around, looking for all the stuff that's not so close to them, and that's what babies do. What is the single most important factor to consider when communicating with children? So we know you got to get on their level and then, physically, and then on their developmental level. If you're not going to talk to them in a manner they understand, then you don't talk to them. Because what we're doing is we're trying to get that child to do something or to have something done to them that they wouldn't want done, but communicating with them in a manner that they can understand it and can work with it. It's really hard. But children are fun once you can learn. What 2-year-old child pain assessment tool should the nurse use? What do you use for a 2-year-old? So 2, from 0 to 3, it is FLAC. From 3 up to whatever is FACES. And remember, FLAC is also a non-verbal child. Whether they're 18, cerebral palsy, they're non-verbal. You could also use FLAC. You need to know these ages. 0 to 3 is FLAC and non-verbal. 3 up to whatever is your FACES. And we know numeric, they say above the age of 8 and above. At 6 months, an infant's birth weight should do what? They grow quick. So at 6 months, a birth weight should double. Why do we look at that? And why do we want to know that? Well, what if the baby was born at 7 pounds and at 6 months that baby weighs 9 pounds? That baby has not gained the weight that it needs, but it's just not the weight. We're not giving the gas and the tank to feed the brain and the muscle and the body and the growth. So cognitively, that child's not going to be rolling over completely like they should be at 6 months. And we will see that. It will be obvious. Also, what if the baby was born at 7 pounds and is now 18 pounds? Well, we've gone the opposite direction. Now, how do we look at diet and how do we change it? Any question on your NCLEX, on your HESI, on exams, when it talks about a problem with weight, the first thing that needs to be done is a food diary. What did you eat for breakfast this morning? What did you eat yesterday? Or here, what did you eat in the last 3 days? Food diary will always be your answer. The first expected fine motor developmental milestones for an infant begins with, what's the first thing I told you they do with their hands? F is fine. F for fingers, hands. What am I going to do with my hands? First thing I do with my hands. And we're going to go over this more next week when we go over infants and your toddlers. The first thing that happens is that reflex palmar grasp. And then we do voluntary. And then it starts with these using the fingers more, closely. First, it starts with a crude pincer grasp. It's like taking Cheerios off a high chair and smooshing it in the face. And then all of a sudden they go with a really fine, one at a time, putting it in the mouth. That's a fine pincer grasp. By 11 months, they should be able to take things into or out of a container. And by 12 months, with their hands, they should do block of 2 blocks. 2 blocks. They should put one on top of the other. That's F fine, fingers, fine motor development, first year of life for an infant. An 8-month-old infant should be expected to perform which fine motor skills? According to what I just said, what do you think it would be? Well, we know we don't put anything in or out of a container till 11 months. We don't build block towers by 12. So the only answer it could be is that grab that rattle, but we're still on that crude, like using the whole 3 fingers instead of that really fine pincer grasp. Okay, it's okay. You'll figure this out. You're going to see it again and again. I'm going to help you. The natural physical developmental sequence that most children follow is, what's the first physical? It's gross motor skills. It's the get up and go, go, go. It's movement. What's the first thing they do? Remember, there's a sequence that they follow. They lift their head first. It doesn't matter anything else, did it? They lift their head first. Very good. Good job. Which behavior indicates that an infant has developed object permanence? I didn't go over this, but I put it here out there and because it's something you need to know. Take an infant and show them a toy. Hide it. Once you show an infant a toy, they know it's there. That's object permanence. So what do they do if they know that toy's there and they want it? They're going to go looking for it, aren't they? And that's going to help with all that motor and all that movement and all that sort of stuff, right? They're going to actively search. Think about that 1-year-old who you take that, fire truck and you put it in a toy box. They wake up first thing in the morning to go right over to the toy box and get it out. They know it's still there. Infants know it too. They're smarter than you think. In general, an infant should triple their birth weight at what? So we doubled it at 6 months. So we triple it at 1 year old. Do you know when they 4 times their birth weight? They're 2.5 years old. You see the difference between the first year of life and on that first year, they're getting taller, they're gaining weight, and then it all slows down. So for when they're doing 4 times, it's going to be at age 2.5. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning this examination. Remember toddlers, ages 1 to 3. I think they're the most skittish of all of the children, the most untrusting of all. These children need to be on routines. These children need mommy. They need their important security objects. And remember, get down on their level and make sure always you're on their developmental level. Remember, it could be a 2-year-old who's smarter, who's more like a 6-year-old. Again, know your subject. And then you could make their stay at a hospital or in a emergency room or a doctor's office a lot better than it could be. According to Piaget, toddlers are in the blank developmental stage. Piaget, this is all about thinking. Right? Thinking. Taking this thing and building these schemas into something more and more. It's from learning how to breathe to learning how to eat. It's called the sensorimotor. Remember Piaget. How do we learn? We learn through touch. We explore the world in our mouths and we move it around and make it work. That's sensorimotor. Which intervention helps a hospitalized toddler feel a sense of control? Remember, toddlers do not like change. They do not like, things that are different. Remember, we need to try to keep a toddler, ages 1 to 3, on more of a routine. So, mom, when did you give bath time? That's a big thing. If a child is used to a bath time at night before they go to bed and you change it to the morning, they don't understand what's going on. They don't get it. Also, if we can incorporate their diet stuff into the diet, if it's possible, we need to try to do that. Again, those usual routines, feeding, bedtime, are extremely important. And if the child is cognitively delayed, like with Downs or autistic, it's even more important. That routine is so, so important. It makes them feel, I know what's coming next. I'm okay. They don't stress out. Do all children reach developmental milestones at the same age? Nope. and they will not. You have some children that are walking at 9 months, and then you'll have my kids. They didn't walk till they were 15 months old, and they never walked. When they counted how many steps that they did 76 the first time. I'm like, that is not walking, that is running. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care for an infant? What did I tell you about atraumatic care in infants? What works? Provide sucrose solution on a pacifier. Good job. Whoop, whoop. Which of the following immunizations is administered to a newborn? I'm just showing you that you're going to get some questions on immunizations. Next week is on infants. There's a double page of them. This is one of the immunizations you need to know. And you have to know that it's actually a 3 series, and it is hepatitis B, usually given in the hospital before they leave, and that usually 6 months, and I believe at 4 years, if I'm not mistaken. The normal heart rate for a neonate is what? Remember, you need to know the vital signs of the child you're taking care of. If you're looking at fever, you're looking at dehydration, looking at giving medications. So that vital sign sheet I gave you is a guide. It's not an absolute, because you're going to see them all different in many different places, but it's a basic guide. Neonates are 140 to 160. I mean, if I was going to give a neonate digoxin and my heart rate was 100, we know that's not right, and we would hold it. Again, those are the type of things you need to know heart rates for, okay? Which is a preferred site to give an injection to an infant? And please don't do it in the method that this picture shows. You need somebody holding that child's hand or a pacifier on that poor infant's mouth, right? It's called the vastus lateralis, and we give it there until they're up and they're walking. The death of an infant under 1 year old with no known cause. And we're going to go over the reasons and the risk factors for this next week with the infant chapter. And it's called SIDS, or sudden infant death syndrome. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why? Remember, there's going to be culture wherever you are. And, it's giving respect, and it's also taking care of the child. And this is actually one of the things that is showing respect. Okay. And again, how would I know? Well, I could ask, I could, look it up, but usually I'm going to ask the person involved, and they actually feel better because, like, you're respecting them, and you ask them why you took that time to do that. A child from Mexico is hospitalized for a serious illness. The father says the child's being punished by God. Why is he saying that? Again, this is another thing that is a common belief in this culture. So again, if you don't know, you can ask. I mean, just support the parent, support the child. Which term refers to times in an individual life when he or she is more susceptible to positive or negative influences? This is actually called the sensitive period. This is time where they can learn, whether it's good or bad. This is where they're more susceptible of that learning. What is characteristic of the pre-operational stage of cognitive development? This is the young kid and learning. And it's the intaking and the sensor or motor sort of learning from them. What sort of learning do they do? And I know this is confusing, so let me try to explain it. When we talk about young kids, they don't know how to do something until they see it, right? Thinking is concrete. Concrete, you can see it, touch it, feel it, smell it. It's there. That means I already know it, okay? It's concrete. I see it and touch it. Once I see it, then I can replicate that. It's part of my learning. You showed me how to take the rattle and shake it. Now, I've seen that before. Now I can shake it. These are the things as they learn, they've seen it, I know it, it's concrete, okay? They can't figure it out by themselves yet. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler's stage of moral development? Preschoolers, what do they know? I've always said preschoolers are reward and punishment, right? What's another word for that? Again, reward and punishment, right and wrong, and a consequence for each, whether it's a good thing or a bad thing. That's what Kohlberg says. And when we talk about Kohlberg, it is usually preschoolers. It's usually that reward and that punishment. All right, let's see how we did. Number 3, Gracia. Good job. Number 2, Vicky. Oh, good job, Vicky. Number 1, drum roll. Bing, bing, bing. Shay. Good job, Shay. Number 4 is a Jay and a Brit. So this is my class for today. Because we didn't take any huge break, we always get out early. Usually. There's times where the class is a little bit longer because it's so much information that I have to give, but usually we're out a little bit early. Remember, next week, first thing is a quiz. We'll do that first. Usually that's from 2 to 2:30, and then after that, we go on with our class, and we get whatever else we need. We'll get it done. Next week is your infants, your toddlers, and preschoolers. Take a peek at your book before you come, or look at another lecture I've already done, and then come to me, and then we'll get you going for pediatrics. Any questions, comments, concerns about anything? Remember, if you need something, what do? Communicate, all right? You guys have a great day. Nice meeting you all.
Thanks, you too.
I'll have this posted
Thank you.
pretty
You
soon.
too.
Bye-bye.